Thank you, everybody, for joining us. We have two physicians from California today. They will introduce themselves shortly. This is the first in a series of mini chats that we're going to have with various doctors, nurses, hospital administrators from across the globe, from the epicenters of this pandemic. We decided to do this because, one, we felt that it's our way of essentially saying thank you to all the frontline workers that are in the middle of this pandemic, trying to save all our lives. And also, we are hoping that whatever wisdoms and insights and experiences that they share may be useful for doctors and nurses and hospital administrators in other parts of the world, and there may be some lessons people can learn. So hopefully that's the intent of having these conversations. So thank you so much, Dr. Rosen and Dr. Chaudry, for joining us today. If you don't mind, Dr. Chaudry, if you want to go first, introduce yourself and so the audience knows a little bit about you, and same for you, Dr. Rosen. Great.
Yeah, sure. Thank you so much for the invitation to speak. So my name is Dr. Tariq Chaudry. I'm a pediatric hospital physician at Kaiser Santa Clara Medical Center. I also happen to be the inpatient division chief of pediatric services here. And primarily my role is to see pediatric patients in the hospital that maybe come through and consult in the ER. I do cover the ICU as well as the pediatric ward and take care of children in the nursery. I also have in our system, we have a regional system where we're a healthcare system taking care of 4.5 million patients. And we have 21 hospitals in our system and multiple office buildings and outpatient centers. And so I'm the regional director for inpatient pediatrics for the Kaiser Permanente Northern California region. So I have some oversight over services and some connection to some of the COVID response for the pediatric perspective from inpatient.
Wonderful. Dr. Rosen?
Yeah, so I'm Dr. Kerstin Rosen. I am also a pediatrician, and I'm working at the Kaiser Permanente Santa Clara Medical Center. And as a difference to Dr. Chaudry, I work primarily in the outpatient setting, so in the clinics. So that's where my usual days are spent, and has been for the last 13 years since I joined this big organization. And we are, in fact, a tertiary medical center in the heart of Silicon Valley, and then we are the southern referral hub for a lot of the other Kaiser facilities that are a little smaller than we are. And so that's why we do have the big medical center where Dr. Chaudry is the inpatient HPS lead, if you will. And I work primarily in the clinic. My jobs there, in addition to seeing patients from 0 to 18, also involves doing work regarding continuing medical education to make sure the frontline pediatricians in the offices are practicing up-to-date medicine. And as Dr. Chaudry, I'm the chair on the outpatient education side for the pediatricians in Northern California, Kaiser Permanente. In addition to that, I do participate in some other programs that we actually figure out how we can come up with innovative processes, both within the hospital, but also in the clinic setting, and how we can improve the care we deliver to our patients. So that's one of the groups I work with, including our communications team, where we have physicians actually assisting each other in becoming better physicians when we're interacting with our patients and with our staff. So we put together communication programs for that. And so that's another group that I've been working with over the last some years. So that's some of the roles that I have here at Kaiser Permanente.
Well, very impressive two individuals, and we are very, very fortunate to have you, and thank you so much for taking the time to talk to us. I'm sure that these last couple of months have been sort of a unprecedented sort of thing for you as physicians. I mean, I can only imagine it's been a complete sort of transformation for all of us, civilians, as I would call ourselves, waiting for the medical teams to successful beat this thing back. But it must have fundamentally sort of changed your lives, I would assume, pretty drastically. How has this pandemic impacted you personally in terms of your practice, for example?
So I think, and that's an interesting question, because we did not come prepared for this pandemic in the world. Obviously, it came on so quickly, and it seemed like we were hoping that maybe it wasn't really going to come our way, but at the end it really was. And so it wasn't a matter of outrunning it, but it was about trying to figure out how do we deal with the situation that we're in, and how do we support our patients and can do the job that we need to do. And I think there's an advantage of the system we're in. We already are a huge integrated network within the Kaiser Permanente, which certainly helps. So we came prepared probably way better than a lot of other systems, because we have been practicing this kind of integrated system for many years, including virtual visits. And so all of a sudden, we had lots of patients who needed care, but of course, with shelter in place and needing support, they primarily need the support at home. And I think you'd be surprised how much you can actually manage over the phone and virtual visits and stay attuned to the patient's need, but also stay in contact with them and update them regularly. And by doing so and keeping them informed and feeling that they did not lose connection with us, they had an option to come in and see us if they needed to. It wasn't like they were turned away, but primarily everybody jumped on the idea of, can we please try to go virtual as much as possible? And
the challenge before, right? I mean, virtual. I mean, I'm hearing a lot of people who are in the telemedicine space that, now finally doctors and patients more than doctors are sort of caught on to the idea that that's not a bad thing. Maybe I should just stay home and instead of going to the hospital where I may have an increased risk of getting COVID. So this has changed the dynamic for you of patient care in terms of virtual versus inpatient, or?
I think, that definitely changed the way we interacted with our patients has been changed, because when you go from actually seeing patients in the clinic one-to-one, there's definitely there's some benefits to that, because you can feel the tension or the anxiety. You can read body language. You can also give reassurance. Now you're sitting and talking to them on a screen when there's a lot of distractions and things like that. However, I think you'd be surprised how much you can actually get out of that kind of visit, and how much you can assess, even in a child that is jumping around. If they're complaining of leg pain, if you can see them crawling around or jumping behind the mother, you're not as concerned for some serious issues if you're actually able to do so. So I think that was different. But I think now we had two motivated parties, both us on the medical side and the patients. And so when we are in fact seeing our patients, everybody wants to get to the point and get the education that they need and information. And again, trying to keep people from getting the care that they need. So that's been a change, and everybody's been really, I think, I've been amazed to see how all colleagues have just stepped up and done exactly what needed to be done to both care for patients, but also be able to care for their own families while dealing with the pandemic. So, as you know, the schools shut down and the daycare shut down, and that affects doctors and nurses as well. So in any case, that was a huge change. And so what has it been like for you, Dr. Chaudry?
Yeah. Well, yeah, we, in the hospital setting, we've certainly had, I would say, conceptually some similar challenges, but things are very different in the inpatient world. With this change, a lot of us are really, the first thing we had to do is think about how we created a safe environment with this potentially, when it started, it was very unknown about, what's the mortality rate, what's the lethality, what's the infectivity rate of this virus. So we had to plan for the worst. And we really had to spend a lot of time learning as rapidly as we could about the most critical effects of the virus, how to protect ourselves, how to focus on personal protective equipment. So everyone was concerned, like job one was safety in the hospital. And that was mixed in with a lot of fear and anxiety for both doctors and nurses that in that setting had a heavy risk of exposure to potentially very sick patients coming in. So a lot of what we did was actually really quickly try to figure out where we could get enough personal protective equipment. We did this as an organization, as Dr. Rosen mentioned. We have a huge amount of resources directed toward to doing things. There's a huge disaster response component, and I participate that in a level for PEDS. And we've had things like strikes and fires and other critical event scenarios. And we were at a high level, we were very adept, and we had an infrastructure to help us plan for this event and help us work through, create protocols, help us source personal protective equipment. That being said, it was still very difficult. The national supply chains for protective equipment, for things like swabs to test for COVID have been severely affected. And we had to deal with a reality where we were short of these things that we take for granted on a day-to-day basis. And we had to try to adapt our workflow to deal with this unknown virus and deal with limited supplies and do our best and say, where do we really need to wear a type of mask, or where do we really need to wear an N95 mask? And it was, it's been stressful for a lot of us because we had to really look down and really study what were the effects of the virus that were known, and look at the epidemiology, look at the science. And that was a big challenge. It was a big change. And once we figured that out, we had to train everyone in the hospital and get people aligned around it. All the while we're combating people's fear and anxiety, people worried about themselves, their health, people worried about getting sick, taking the infection home to their family, infecting their kids. We have people, nurses in the hospital that have kids with immune deficiency, and you have to really think about people and their safety when you're dealing with a pandemic or scenario like this. So I think that was a big effect. We really had to make sure that we were doing the right thing for people. And it's taken a lot of energy and a lot of effort. So you've done all this preparation, the fact that Kaiser is, very well integrated to begin with from day one. And I know that from a system standpoint, I actually used to sell software to Kaiser in a very previous iteration, these are integration software. So I actually know a little bit about the fact that, you're a very technology savvy organization. Now with all this preparation, were you surprised at the numbers, or were you pleasantly surprised because there were less cases than you anticipated, or has that been sort of, because everybody's concerned about kids getting COVID, I think, understandably so. So is there an upside in the story that, you didn't get as many cases, and that's a good thing, I would assume, or is that been that you were getting what you were expecting in terms of the case load?
So I think, we didn't know, as Dr. Chaudry was saying, and so the unknown was really, really scary, of thinking, what is this going to do? Because the data that was coming out of the other side of the world, probably wasn't necessarily accurate, and we didn't have the results to look at, were we testing those children over there? Were they getting sick? Were there some other problems in those children that just wasn't reported somewhere? And what was the impact going to have on these kids that we are in fact seeing here? And again, in the beginning, as Dr. Chaudry was pointing out, there was definitely this concern that we weren't able to test. And so you don't know if you're having children that parents are reporting having it. This arrived in the middle of the flu season. So don't forget that there's actually influenza around, there's RSV around, there's other viruses. And in the usual practice, we would have seen these patients in our clinic, and we would have assessed them, and we would have been able to maybe swab and send that for testing and assure the parents that in fact this is just RSV or just influenza, if you just say just, but given, COVID being the other concern, when you all of a sudden find yourself maybe not being able to do so because we weren't sure if we're going to need to reserve some of those swabs for the COVID testing until we knew we had adequate supply. So it was a lot of hustling and trying to reinvent kind of what needed to have happen, and how to also swab the right people to know what we're dealing with. And I don't know, we still didn't have enough testing in the beginning to know the extent of the COVID-19 in children. And in fact, were the children actually having COVID-19 and were they just not as symptomatic as we maybe would have feared? And at this point, we still don't have that data because we didn't swab them, and maybe at some point we'll do antibody testing, but the verdict is still out on that in terms of the accuracy to see kind of maybe there was a bigger cohort of patients that in fact were walking around in our society, and maybe they didn't get as sick as we had really truly feared. And
we don't know whether kids are less impacted or more impacted, because you're saying that the testing and things like that, so they may be asymptomatic. I mean, that is still a question mark. Is that what you're saying? Am I hearing you correctly?
Well, Dr. Rosen, if I can chime in. So, we do have, some data reports from around the country, of data reports from Italy, China, looking at other areas. And we have our own internal Kaiser data from Northern California. I would say, in summing all that up, the large summary is kids are not as affected by this. especially in the 0 to 10 age group. They're not as affected. Those that are infected, actually, probably about 60% of them tend to be asymptomatic. They could potentially transmit the virus or could be viral shedders, but they're not really showing what we see in the way of heavy symptoms. A few amount of kids, I could count on one hand the amount of COVID positive patients that have been admitted to our system for pediatric patients. Many of them are actually being managed by our outpatient colleagues and our infectious disease specialist as an outpatient and are minimally symptomatic. And only very few have had to get admitted to the hospital. And that's looking at all the data. You know, we have very good data tracking in our system, especially for a lot of the inpatient stuff. And it's very, very few. Most of them look like they're asymptomatic. Looking at, you know, we had a sense of some of this, even like we had friends looking at listservs in Italy and people talking to people there. And some of the things we heard back in February and March were that there were children's hospitals that were empty over there, despite this big pandemic going on. It was hard to come by pediatric data, even out of China. You know, there were case studies, you know, and the first case study that came out is there were basically, you know, there were like 2 pediatric deaths and very few numbers of kids in the study. There wasn't enough data out there. And kids haven't been affected as heavily as adults. And so that's just something we're seeing from the early data that could certainly change. We certainly have this new, this syndrome coming out called the multisystem inflammatory syndrome in children, or MIS-C, as it's coined by the CDC. This is a new entity that's being recognized and is similar to, you know, a disease called Kawasaki's disease or toxic shock, that are basically autoimmune attacks that happen that are triggered by something. And often they can be triggered by viruses. So we're seeing some of that, but again, very few numbers of that. So the overall impact to children, as far as the data that we have, even worldwide, is that they're less affected, they're not as sick, but they can be asymptomatic carriers. And they can't, you know. So as Dr. Rosen was mentioning, even with our limited testing, there may be even more out there that we're not seeing. But most of the severe impact to children is rare, and many kids that are getting sick are asymptomatic. So it's kind of a positive in that way.
Yeah.
I mean, children don't have comorbidities either, right? I mean, they don't have diabetes and all these other complications. I mean, there are exceptions, but
yeah.
But maybe
well, yeah. There can be kids that do have we call them children that are medically complex.
Right.
Kids that may have developmental delay. They have a tracheostomy. They have a feeding tube in their stomach. They have, you know, cerebral palsy. There are kids that can be affected, and we do worry about that population as well. But we haven't had enough, I guess I would say, at least in the Bay Area, the disease prevalence, or we're looking at the test positivity ratio. So of all the people we test, how many people are infected? You know, and we're probably, in our Kaiser data, we're at about 4.5% of people being affected, and even less of the, you know, of that group, we have 5%, 4 to 5% that are children. So it's a small cohort, and even less are kids that we're seeing with our limited testing. You know, we've tested about 4 to 5% of our population, and that's like, you know, like on 4.5 million. That's probably a pretty good sample size from an epidemiological standpoint.
Hospitals and doctors like you are also challenged. I mean, it's not like everybody else stopped getting sick and we only have COVID, right? So I mean, there's a whole slew of people who are still getting sick, I'm assuming, right? That, you know, and hospitals were never sort of, you know, places where you had, you know, 70% of the beds free. I mean, you know, they're usually quite full anywhere in the world, I would think. So what happened to those patients? I'm curious, because I mean, we don't really hear a lot about that. But as pediatricians, you guys must be seeing this. I mean, you know, kids get sick, people call you, right? I mean, so that must be still happening, I'm assuming. How is Kaiser?
I mean, children still fall down and trip down and jump on the trampoline and end up breaking, you know, some bones. That's absolutely true. And there, of course, it's not like in adults though, with the prevalence of you know, heart and renal disease. We don't have so much of that in pediatrics. But we know, I mean, that's the good news here too. Within a system that is integrated, we are very, very much aware of where some of our risk patients are, and that we touch base with them, which we have made a huge point out of doing. All of us physicians have actually prepared lists of patients that we have outreach to that could potentially be vulnerable, that could be not seeking care for their usual underlying problems because they are in fact worried about coming in to seek care for that. And we've been doing that as virtual visits and supporting them with education, making sure they have adequate medication at home for what the underlying problem is, and really reaching out to them and making sure that if there are any concerns regarding other problems, they need to be in contact with us so we can act on that early and provide safe care for them during the pandemic. And so I think that has worked really well. But again, that's because we come prepared and come with our integrated system. And I know that's been really well received amongst all those children, for example, that are struggling with maybe a child, not just with developmental delay, but there are other children with, say, severe autism, and they may also have asthma, and they may have other things, and where communication between the parent and the child may be limited. And how do you assess the child for their needs at that time if there's an issue with them medically? And how do you do that virtually without necessarily sending them to the lab and x-ray and whatever else you need to do? So we've been trying to be really creative and staying on top of those patients to make sure that in fact none of that chronic care management is going to be suffering, even though we're in the middle of a pandemic.
So you're like the on your side, you're making sure Dr. Chaudry doesn't get many patients, right? So
no, that's totally true. That's totally true.
Well, yeah, exactly. So if Dr. Rosen does her job well, then I get put out of a job. But our preventative care arm at Kaiser Permanente is so fabulous that really, even on the inpatient side, we practice medicine different than other community, like say children's hospitals or other hospitals, because we have a lot of care that's being provided, and a lot of serious complications are being prevented before patients get to the hospital. And that's one of the really great benefits of our integrated care system. For what you did ask about what's happening in the hospital, and we certainly do have, I would say, we do have patients in the hospital. The volumes of all patients have decreased because, this may be a negative consequence, but fewer people are presenting to ERs or presenting to care. And especially in the adult world, there may be things that are missing. People do recognize that there's decreased, myocardial infarctions or congestive heart failure. There are fewer patients coming in, especially on the adult side. In the pediatric side, social distancing and shelter in place has really affected not only does it suppress the spread of coronavirus, but it also suppresses the spread of all viral disease. And while the disease like flu and RSV and other things are still out there, they're actually suppressed because kids aren't in school and spreading them. So we actually have a less volume of patients, especially with an infectious disease, coming into the hospital. Now, what hasn't changed is as Dr. Rosen was mentioning, kids still break bones and fall down, and we've had kids had head traumas. We actually the number of cancer patients that we have has not changed. We deal with children with cancer at our center, and we're still getting those same admissions, and the cancer service is still the same. One big thing that's changed throughout all the healthcare system is providers are doing fewer elective surgeries or non-emergent surgeries, and surgeries are getting postponed. So there's definitely less of that going on. And I apologize, my Roomba just turned on. Okay, shut that off. But so volume in the hospital overall is less. Hold on one second. Can I run out and stop that?
Yeah, please do that.
Okay.
Interestingly, you mentioned a couple of times, Dr. Rosen, this integrated approach that Kaiser has. So I think you were also talking about, some of the dermatologists being, seconded to do other things. I thought that was brilliant, actually.
Well, so what happened is that when a pandemic happens like this, as if we're not talking about when it happens like next time, what we're saying is that it struck us now, and we didn't the world wasn't prepared. So we figured out, as Dr. Chaudry was saying, we're not going to do elective procedures. People are not going to go in and have their moles removed. They're not necessarily going to seek care for acne when you're going into a medical center of the concern of having too much foot traffic in a clinic and in a medical office building. So that's obviously not advisable. And so all of a sudden, I think some of the patients that were infected at home weren't as bothered by the acne either. They're kind of thinking, in the scheme of things, I truly don't need to seek care for this right now. So of course you have then specialists that are working, or doctors that are working in outpatient setting that, and also inpatient in terms of doing elective procedures that were available, and they're trained providers. They have lots of expertise and they can certainly be redeployed. And what we try to do is to say, who can step into some roles and support those patients and support some of the neurosystems that we have developed to make sure we have a resource for our patients. And so, yeah, so then we did, when you do test some of these patients, you need to respond to them. But as a clinician who are actually seeing patients in the clinic every day and dealing with my everyday appointments, I may not have time to spend just actually educate the family as much what it really means to have this lab result come back and how are we going to monitor you. So we then had other providers per protocol step into those roles and be the reporters and communicate both in writing, but also calling a virtual visit and really discussing and educating the families what it really meant to either have a positive or negative result and how this child still needed to be monitored closely, etc. So by doing that, we were actually just, using our skills as providers, whether you usually remove molds, but there's no reason why you can't communicate medical information to families. And so that's been really, really helpful. And on an anecdote, I have to say, we had lots of staff because, we had truly reduced the number of patients that are allowed to come to our medical center. They're screened on the phone beforehand. They're screened at the door. Only one parent, if they come in for well care, were actually in fact allowed in to our clinics to have the baby seen and have their vaccinations, which could not be delayed. And by doing so, of course, we also had needed extra staff at the doors that are usually not there to make sure people get screened and educated as well, and questions answered. And I had an anecdote right in the beginning there where you could feel the tension in the medical center that where are we, what's going on here? And it was kind of eerie almost to see this new sort of a protocol, if you will. And we have a big entrance hall, if you will, auditorium almost like, right. And there's a big grand piano. All of a sudden, I see this orthopedic surgeon who had been deployed to actually be one of the greeters and the people who they can go and ask when they arrive. He uncovered the cover for the grand piano, and he sat down and started playing music. And it was like, I almost thought of it as it was on Titanic when the music played on. It was that feeling. It took all of a sudden the tension at that moment was reduced. I don't know what kind of level it dropped. People just stopped and looked at him and was like, thank you. That was just what, like, that moment we needed. Something in addition to sort of just like protocols and this is what we need to do and hunker down and do the job. There was that little extra of let's just take a breather right now and calm everybody down. And so who knows what you can use an orthopedic surgeon for when he's not doing elective hips.
Sharing a sort of interesting, I read recently that in India, the number of the deaths at the crematoriums are not busy. And that's because India has one of the highest accident rates in the world.
Oh, yeah.
So because everybody's locked down, nobody's on the road.
Right.
So, the crematorium guys are saying, hey, I used to do so many bodies a day, and now I'm down to like one a month or something. What's going on? You need to give me subsidies now. So it was interesting. You don't realize some things that drive morbidity. Morbidity has to do with something as simple as getting a car, right? Or a bicycle.
Yeah.
Yeah,
I actually had my own, I left the hospital one afternoon and there was like one of those manholes that had been turned like perpendicular, so it actually blew up my tire. And so of course, it almost sounded like an explosion and it was outside the hospital. So they're thinking, what's going on, if there's some emergency of some kind. So anyhow, the first responders came because they were called. And you're right, I think what ended up happening, didn't need to be out on the highway. So it was like 6 cop cars, a fire truck, and everybody standing around talking, looking at my car. And I'm thinking, you're right, there's a lot less people out on the freeway in Silicon Valley. It's usually packed, clearly, when you can deploy that many people to this little car popping.
I'm talking time, so I just want to ask one question from both of you, which was, with obviously the benefit of hindsight, what would you have done or could you have done differently, in preparation for something like this? And obviously now we're going to have potentially more future pandemics. I guess after the first one hits, then you sort of prepare. But what would you do? I mean, in hindsight, what would you have done differently in terms of preparation? In each of the different areas.
Yeah, I mean, I think, you know, part of our disaster preparedness that we do on a daily basis, or, you know, we have drills, we always prepare. You know, I think although we do some preparation, you know, some, especially frontline staff, try to think about this, but maybe didn't think about the impact or take it as seriously. So while we do train, does everyone show up to the drills, and does, you know, everyone, you know, I think that there's going to be a heightened sense of recognition of something like that, of making sure to pay attention to those training opportunities, and to practice and to simulate and to get ready for things. I think from an organizational standpoint, I think every healthcare organization in the world is going to take a hard look at some of the things that happened, because really we had the effect of like global supply chain and logistics affect every healthcare system in the world. Not, you know, and especially I go back again to not having enough personal protective equipment, gowns, gloves, testing equipment, things like this. And because of the way our system is set up, we were all caught off guard. And there were shortages everywhere when everyone needed the same equipment everywhere in the world at the same time. And I think everybody, you know, globally, people have to take a hard look at the way you manufacture supplies, the way you're able to get things like gowns and gloves and N95 masks, because this has really put a stress on everyone. And I think we have to think about that. And I think that my personal opinion is that it may drive change in the way people manufacture. Like maybe there'll be more domestic production of personal protective equipment, so you can actually replenish stockpiles, pay attention to that. And I think, you know, Kaiser Permanente is a big organization. We did have our own internal stockpiles, thankfully. And I think that really helped us get through. We did much better than other organizations did. But that being said, you know, it's a lot of, you know, they talk about winning wars is not about tactics, but it's about logistics and getting supplies. And the same thing is true here. And I think we may even take a harder look at how we secure and procure equipment. The other thing, again, I mentioned training, is I think we have to learn how to take care of our people and communicate. I think we did a pretty good job. There's always opportunities to learn more, but there are two pandemics, one of the viral pandemic and the other was the pandemic of fear that happens in the population and also in our own people. And the best way to combat the pandemic of fear is with information, with facts, with science-based evidence, and to really get out there and get that information out there rapidly to people. And we've done some amazing things already using a lot of virtual care, a lot of like technologies to support video meetings. And we actually increased the amount of education we've done, and having a lot more conferences, telling people about what's going on. And that's really been amazing for a big organization such as ourselves to actually, I feel like, improve the amount of communication people had because it was really important. I hope we keep that up in the future, and I hope we do an even better job of it. So those are my kind of thoughts on that.
Excellent.
I couldn't agree with you more. I think that's exactly true. In terms of the education regarding, on the hospital side, obviously they do a lot of consultations in the emergency room, so they are used to going down there. When you're working in the outpatient clinic, it has been an option to go through disaster drills and training, because it almost feels like maybe it doesn't pertain to me. I have opted to go because I think it's very interesting and I've learned, and that sort of got me involved in a lot of projects, I think, that around this, to figure out how are we going to work and how can we get redeployed. So we did have, in fact, several pediatricians who agreed to go through training to be able to go if we had to open up a pediatric tent, for example, and really practice emergency medicine in pediatrics, that we went through training to make sure that we knew the emergency room electronic health record system, if you will, which is different than the outpatient. How do we then work differently than we usually do? So we did do those things. I think that's something that we're going to end up asking everybody to actually do on a regular basis to encourage them to really get comfortable so we can get redeployed. Are we needed somewhere else? You should be able to go do the job. You're still a doctor who's been practicing for a while and you know your skills. Right. So if it's just technicalities, we should be able to overcome that. I agree with the personal protective equipment that was really scary to hear that maybe there will not be enough masks. So are we going to ask people to go in and see patients when we don't know what we're meeting in the exam room and what beast this COVID-19 is and what it's going to do to me? And if I bring it home to my own children, if I don't have enough protection, can we ask our colleagues to do so? And everybody was trying to figure out how you can deal with this. And we were very, very fortunate within Kaiser Permanente. First of all, we're a big organization. We have a lot of leverage and obviously a lot of support and an organization that actually came prepared and already immediately had this taken care of, versus a lot of my colleagues from the community started calling me, asking me, Dr. Rosen, how are you guys handling this? What kind of equipment should we be using? Because we're depending on the Department of Public Health to share information, but there's very limited information. And when you call the Department of Public Health, they're inundated of phone calls from small community pediatricians or other doctors, and they're trying to solve those problems. So realizing we're in a big organization that helps us deal with this, but all systems should have been well prepared, and this should have been not just a federal, but a state also preparedness group that had everything available. So here's where you can go. Here's education for providers to take the anxiety down in you as well. Because how do you go back as an ear, nose, and throat doctor and open up your office when in fact you don't even know if you have ventilation that goes outside the building when you're going to start seeing patients? How are you going to tell your staff to gown up, and where are you going to get your things from? And so everybody had to fend for themselves. And I don't think that's okay in 2020 the United States. I had talked to a lot of people. I've been on the phone with the Congresswoman Jackie Spears' office multiple times, trying myself actually to see if we could get some sort of a Good Samaritan clause or provision put in place from early on, because we were lacking some of the protective gear. And I had actually asked a lot of the companies, high-tech companies in Silicon Valley, I said, you have the equipment, you can actually scale for some of these smaller companies that are making some of the protective gear that has an IP on this, and we can have you make that. But we obviously don't want to have any kind of IP infringement. So how can we have some clause that allows quickly for a sort of collaborative effort between the makers, like a small company, to then have a boosting, sourcing, quick scale company that can support them during a pandemic. And I personally think there needs to be legislation and support for that legally, but also there needs to be some sort of demand on some of those providers of the PPE to say, in a pandemic, what is scaling going to look like for you? Who's going to be the buddy in the community that you can outsource to, that you're obligated to have as an agreement with already, should they need to push that button to support, so we can internally within this country support our providers so they have the right PPE.
I mean, I think, thank you for talking to me. I mean, we've reached a grim milestone in the US, over 100,000 dead. I mean, you're definitely in the epicenter of things in terms of, from a global perspective. I mean, it's great to hear sort of the efforts that you're doing, the hindsight information, the insights. Thank you for being on the front lines and making a difference. I know it must take a huge personal toll on yourselves and the families around you and your co-workers. So, I mean, on behalf of patients all over the world, thank you for what you're doing. Thank you.
Yeah, thank you so much.
Pleasure.
Really appreciate it.
Stay safe and God bless. We'll hopefully have a chance to have a chat once all of this is done and dusted. That is actually my wish.
Thank you.
That sounds good. Yeah, thank you so much.
Have a great weekend.
Yeah.
Okay, you too.
Okay, thank you.